My name's Jennifer Manuel. I'm one of the orthopedic doctors at our JOI South location. I'm a hand and upper extremity specialist, and I probably know some of you, but I don't take call here, so I don't get a chance to meet a lot of you who spend time mainly in the South ER. But I do work in my elective practice here at Baptist South, and I had some feedback from some of you about trying to give you some tips and kind of suggestions regarding splinting in the ER and the things that we see that we like, the things that we see that we don't like, just to try to get some better care for the patients that are coming out of our emergency room. I have several people here with me today. Julia is one of our hand therapy specialists who works at our downtown JOI rehab facility in San Marco. She sees a lot of our referrals that we have within our group for upper extremity therapy mainly. Ken is one of our splint techs in our Baptist South office, so he's seeing a lot of the splints that you guys send out and applying a lot of the ones that we redo. He's our cast tech, so he sees a lot of things, does a lot of dressings for us too. And Melinda is working at San Marco as well, so she's one of our other therapists. Heather is our office manager here at Baptist South, so any issues or problems getting patients in or follow-up for anyone in the emergency room, she can help you arrange for that or kind of find one of us to help you out if you need us. If you ever have questions, we're always here. So today I wanted to talk to you guys about just some proper splinting techniques and tips, kind of talk about the risks, the benefits of splinting, things that you don't want to do, things that you do want to do, what splints are appropriate for what type of injuries, and kind of how we can just facilitate follow-up care. So obviously the initial approach whenever you're going to be putting a splint on is you really want to assess the limb. You want to make sure the skin is intact, and if not, you want to address that. You always want to check and document the neurovascular status before you put a splint on, just because if, God forbid, something changes after a splint's applied, you want to know it was there before or not. Soft tissue injuries, often you want to just document what you see, whether there's a deficit or a defect in a tissue, tendon, structure, or whatever. And then obviously you want to just assess the bone and joint injuries. Almost any orthopedic or limb injury that you see in the emergency room probably can benefit from some splint or another, at least in the short term. Where I was a resident, we used to splint soft tissue injury. Swelling can benefit from splinting just because the less it moves, the quicker the swelling will diminish. So even if you have negative x-rays, sometimes a splint can still be very helpful for the patient in terms of their recovery. So conditions that can benefit from splinting, obviously fractures, sprains, severe soft tissue injuries, any reduced joint dislocations, you want to make sure you splint properly. Inflammatory conditions, if you see patients with flare-ups from gout, inflammatory arthritis, tenosynovitis, those things can certainly benefit from resting and splinting. Deep lacerations or tendon lacerations are things you do want to splint because in a deep laceration, it can help things heal on the inside, prevent motion so that there's quicker scarring and healing of the tissues. The one thing that we do want to always remember is that when you do apply a splint, it tends to have risks. It's a procedure. So just like a surgery has a risk and a benefit, applying a splint also has a risk and benefit. And you want to make sure that you're not causing more harm than good in what you're applying. So things that can happen from improper splinting is, God forbid, you put the splint on too tight. Patients can develop compartment syndrome from a cast or a tight splint. And sometimes if a patient returns to the emergency room with a lot of increased pain after a splint's applied, you want to make sure it's not too tight. When we put splints on after we've done surgery, fracture fixation, we try to put them on as loosely as possible because we know they're going to swell more. So when you guys see acute injuries, you want to make sure you're not putting things on too tight because you know they're going to swell more in the future, and you don't want that to become a constrictive dressing. Ischemia is obviously an end stage of a similar type of process. You can have heat injury from a cast. When you guys apply the cast most of the time, or splint, most of the time it's cool, but as the material hardens, it has an exothermic reaction. So heat will be released from the material, and if it's next to the skin, it can cause heat injury and burns. Pressure sores and skin breakdown can occur, especially when you're putting splints or casts on and there's not enough padding, or if the patient has diminished sensation, that can be an issue. Infection, especially in the pediatric population, there's been, and I'm not sure if you're familiar with this, there's been a lot of instances in the literature where patients have developed kind of sepsis type infections from, no wounds there, a splinter cast is put on. And sometimes it's from the heat of the cast, and there's been a couple case reports of patients going into sepsis and actually dying from splint application. So, you always want to check and make sure that there's not something new if a patient returns, or just kind of, make sure that you don't see anything that makes you suspicious for something that doesn't make sense. Dermatitis, patients have allergies to casting material. We see that a lot. Even in our clinic, sometimes we'll have to try several different materials of immobilization before we find one that a patient is not allergic to. So if a patient develops a rash or complains of itching, that's something to be concerned about. You probably don't want to reapply the same material. Joint stiffness can be a complication from splinting, and sometimes it's not even the joint that's injured. If a splint is applied over many joints, including the injured one, you can develop stiffness at an uninjured joint that now becomes a bigger issue. And there's been a couple patients I've seen, and I'm not sure which ER they've come from, where a patient's been splinted for, say, a distal radius fracture, and I've seen patients come in with a splint that goes, over the forearm and all the way out to the fingertips, and they're wrapped up, and then the patient's, not always compliant, and they'll come back 3 weeks later with the same splint on, and then we take the splint off, and the wrist fracture, which was non-displaced, is fine, but now they can't bend their fingers, and now that's the issue that we're really working at to get better. So you want to always try to minimize what you're splinting, but splint enough. So, just be cautious of that. Neurologic injury, obviously if things are put near superficial nerves, you can get a neuritis, or again, if things are too tight along the lines of compartment syndrome, you can have a neurologic problem. This gentleman is a dentist, and he was working at home cooking, and he had a mandolin, and he sliced a little piece of skin off the pulp of his thumb. He went to an emergency room because it was bleeding, and they put a pressure dressing on his thumb, and then they took Coban. And you guys probably have access to this in the emergency room. And to prevent it from bleeding, they took the Coban and wrapped it as tight as they could around his thumb to put a nice little pressure dressing on, and sent him out and said, okay, go have some follow-up. Came to see me, I think about 48 hours later, and we removed the dressing, and over the next 24 hours, he developed this ulceration, blistering over the volar aspect, over the dorsal aspect proximal to the nail is a giant blister. And he probably had lost some blood flow to the tip of his finger because the dressing cut off the arterial supply to the tip of the digit. This was about 3.5 months ago, and his thumb survived, but it's still not working properly. And he's been unable to work, lots of disability, all from a little superficial laceration. So things to be cautious of. This is a diabetic patient who had a non-displaced ankle fracture and had a posterior splint applied. And this isn't the best view, but he has this posterior ulcer over his heel. So again, something you want to keep in mind. Other things that can happen, severe swelling. These are all instances of things that, you worry about developing compartment syndrome. Sometimes it's from splints, sometimes it's the injury, sometimes it's a combination of the two. So just make sure when you see swollen stuff, you're putting things on relatively loosely. Prior to splinting, you want to consider the severity of the injury, the potential for instability, the functional needs and status of the patients, and the potential for complications. Make sure that these patients have appropriate follow-up in a relatively, appropriate time frame. And you also want to kind of assess the compliance of the patient. You guys get an idea of whether patients are going to follow up or not, and whether they're going to follow through with the instructions you give them. And if you're worried that they're not, you probably don't want to put them in something that may or may not become a problem. The things that we all take for granted but you need for proper application of a splint, you want to make sure that you have the right things. Tape, bandage scissors, appropriate temperature of water in a basin, ACE bandages, cast padding, fiberglass or plaster material. I think mostly we're using fiberglass in most of the ERs now, and stockinette. But you want to make sure you have everything available prior to applying the splint so you're not looking for things while the splint's hardening. The other thing you need to kind of be aware of is there's different setting times for different types of splints, and the material kind of hardens at different rates. I used to love plaster because plaster is one of those things that it would kind of heat up quickly and set quickly, and you could put like a long leg splint on and not worry about it moving. These fiberglass splints tend to have a longer set time, And so sometimes what will happen is you'll put the splint on, it's a little warm, but then you put the limb down and it starts to kind of just stretch out. So you want to just always make sure that the splint is really firmly hardened before you let the patient be unsupervised or let the splint go unsupervised. The things that speed up setting time is higher temperatures of water are going to get your materials to harden more quickly. The use of fiberglass tends to set up a little bit more quickly. If you reuse your water from one patient to another, that tends to make things harden more quickly because there's always a little material still left in the water. The cooler temperatures make things heal more slowly, and then any plaster. Even though it holds better, it takes longer to set up. Kind of rules to live by: cover any wounds properly after you ensure that they're clean before you apply anything. You typically want to immobilize the joint above and below an injury. That's kind of a rule of thumb. You always want to use some padding. Materials that have the padding built into them are really not enough padding to be right against the skin. So you do want to use cast padding in addition to what's provided by that prefab splint. You want to make sure that any bony prominences or high pressure areas have more padding. The Achilles, the heel, the medial epicondyle, you want to make sure that you're padding those well before you apply anything that's really firm against the region. You want to properly position the extremity, again, before, during, and after the splint until it's hard to make sure that it's staying in the position you want. Whenever you're putting cast padding, plaster, or fiberglass, you want to try to have as few wrinkles in the material as possible because that can be the source of pressure sore development. And then the other thing for your assistant who's ever holding the limb is people tend to have the fingers that they hold, or they're holding the splint, and that pressure in the cast is going to make little dimples. And so sometimes that excessive molding or finger indentation can be a problem with it once it hardens. These are all the types of splints that we recommend, and the things that if you guys want to talk about or have examples of shown today, these are the things that I recommend. I think they're the most common types of splints that you could be applying in the ER, and probably the ones that some of these are a little bit kind of more challenging than others. Some are simple. A volar short arm splint is probably pretty simple to apply. But things like a coaptation splint. A coaptation splint is like a Sarmiento fracture brace for the humerus. I'll show you some pictures of it. It's actually a very effective splint if put on properly for a humeral fracture. So what to use when? A long arm posterior splint, a very standard good splint for a lot of things, especially for elbow fractures or forearm fractures. That's really an appropriate splint. For a distal radius fracture, no one would fault you for putting that on. For a volar short arm splint to distal radius fractures, very non-displaced distal radius fracture, that will hold well. But a sugar tong splint is probably the most appropriate thing to put on a distal radius fracture that you see in the ER because it's going to immobilize, again, the wrist and the elbow, so above and below. A coaptation splint is good for a humeral shaft fracture or a shoulder fracture. We occasionally will see a patient come out of the emergency room with a humeral shaft fracture, which is a difficult place to splint, with a posterior long arm splint on, which typically will end at the fracture. So that's not the best splint. But this drawing on the right side is kind of an example of it's almost like a sugar tong for the upper arm. And it's a really good splint for a humeral shaft fracture. The problem with it tends to slide down. So usually I use two pieces of cast material, one that starts like in the neck and kind of comes down on the outside part of the humerus. And then I usually will put another piece here inside and have them be two separate. I don't have it go around like a U. The things you need to be cautious with is you don't want to have pressure in the armpit. So like an ABD around the top of the inside part to pad. And then this part tends to slide off. So there's that, and I forget what it's called. It's elastoplast tape, the stuff that's like really thick they use for chest tubes. That, if you tape that on the top of the splint to the skin, it tends to hold it really well. So that's a good splint for humeral shaft fracture. Thumb spica splints. A scaphoid fracture, although a wrist fracture, probably is best treated in a thumb spica splint, and anything in the thumb really should be put in that. But aside from that, wrist fractures, I wouldn't do a thumb spica unless there was a really good reason. Flexor tendon injuries. This is just another thing that we don't think about so much is, you splint the hand, you kind of just put a splint on out to the tip if there's a laceration in the hand. If there's a flexor tendon injury and you splint them straight, you're stretching the laceration. So you want to instead do a dorsal splint to keep them in flexion. That keeps the tendon ends approximated as best possible. Similarly, in an extension laceration, you want to keep it in extension and not flexion to keep the tendons reapproximated as close as possible. Ulnar gutter splints are good for 4th and 5th metacarpal fractures and small and ring finger fractures. Radial gutter splints is good for the opposite side, so anything in the index and long finger. The one thing to keep in mind when you're splinting across the fingers, into the fingers, or across the metacarpal phalangeal joints, is that joint is best positioned in 90 degrees of flexion. And the reason is in this diagram on the left, when the hand is held in extension at the MP joints, the collateral ligaments to the MP joints are short. So if they scar in that position, it then becomes difficult to do this because this is the position where the ligaments will be stretched the most. So some patients will have, if they're splinted in an extended position, will have a difficult time getting flexion back. But if you splint them in flexion, extension recovery is not an issue. It's very simple for them to get. So that's something to keep in mind when you try to do it. Sometimes when they have fractures, it's hard to position them like that. But you just try to get them as close as possible as you can. Digit splints, anything that you guys see a lot of these PIP dislocations that you're reducing in the ER, you don't want to splint them in extension because that's a risk of them redislocating out the back. So you want to splint the PIP joints in a dorsal dislocation, a little bit of flexion. That's a stable position for that joint after a dislocation. And then a mallet finger where the patient comes in with their distal interphalangeal joint in flexion, you just want to splint them in full extension. A short leg posterior splint is good for a stable ankle fracture or a foot injury. A long leg posterior splint is good for an unstable ankle fracture. So anything that you reduce in the ankle, you really probably want to put a long leg splint on and have it go across the knee. That's going to hold it in a better position. It can displace in a short leg splint. So immobilize again the joint above and below. These are two examples of splints, and this picture on the right is what we see if, let's say you put this great splint on the left. The ankle is at 90 degrees of dorsiflexion, perfect position, it looks great. You put this orthoplast splint on, it may not have hardened properly, you walk away. The patient then starts to bend their toes down, and now they're in a position of equinus, which is good for, anybody? Yeah, so Achilles tendon rupture would be great for that. But in an ankle fracture, if that patient's left in that position for a long time, they'll get contracture of the Achilles and have a difficult time then getting their foot plantar all the way dorsiflex to walk. So you want to just always check and make sure, and we do this too. I mean, even in the OR with this prefab stuff, it's really easy for it to kind of settle after you walk away. So you just want to be cautious of it. And to be honest, it probably takes at least 15 minutes for it to set up. Probably a lot of the supplies that you have. Do you guys have this Scotch cast stuff in the ER? Is this what you guys are using that you cut like lengths of? What do you have? Do you have the ones in the individual packets? But it's not likely to dry out. You always want to use stockinette. It's the best thing to be against the skin. Cast padding, and then the prefab already padded. We use the cast padding for it because it's better material. And then you want to have your appropriately sized ACE wraps. 6-inch ACE wraps are good for lower extremities, 4-inch ones for upper extremities, just to make it easier for you to prevent those wrinkles. The places to really watch are, again, the heel for anything you put in the leg, the antecubital fossa for anything in the upper extremity, because stuff tends to bulk and bunch in the antecubital fossa and can cause pressure sores. So if you guys have questions, I'm happy to answer them.
What do we do when we have to splint? We have a laceration.
Like what type of laceration? Like a forearm laceration, or
a distal radial fracture, and we have a laceration here that we have repaired.
Mm-hmm.
All over do windows.
You know, if it's something that you're worried about and you want the patient to look for, yes, you can do that. And that can be something where, you know, maybe you splint from the front instead of around the back, or you can always certainly cut an area out of a cast material to visualize. Typically, you know, a lot of times if the wound looks good and you know they're going to get pretty quick follow-up, it's probably okay to put like a sterile xeroform dressing and a sterile kind of gauze over it. You might not want to put Curlex because that can not allow for swelling. But the cast padding over that, because cast padding will allow for more stretch, and then put your casting material over it. So if you want the patient to continue, you know, to actively be checking the wound, make sure there's no infection or something, you probably want to make it something that they can get at, but still have a splint that they can keep on. Because, you know, you worry about if they take it off, is the fracture going to move? So maybe making a little window or an area that they can get to it is helpful. Any other questions?
What do you find is the easiest thing to use to cut the fiberglass or the splint material?
Really good bandage scissors that you're going to have to replace very frequently. These things dull. These are the expensive ones, and these are the cheap ones. The cheap ones, you can probably get some reps to get you, and they only cost a couple dollars maybe. These are nice and can be repaired and sharpened. I don't know where do you guys send them out to someone?
There's a gentleman in town, and he'll come and sharpen our scissors about once a year. I should do it more often, but.
Yeah, but the more you cut fiberglass, the more you're going to dull your scissors, and then it's like torture trying to cut the stuff. So if your scissors aren't working, you need new ones, and you will go through them. People walk away with them too. They're a very valuable commodity.
Yeah.
The main thing I see, as an upper extremity person, is I see a lot of the distal radius splints coming down too far in the hand. And really, if you look at your hand, in order to bend your MPs, your splint needs to end in the palm. So you're not even having it come out. If you have your splint coming out to the end of the palm, you're not going to be able to bend your MP joints. So it really needs to end, like when I put splints on in the OR, I usually take a piece of material, I cut an area out of the palm so that it's kind of curved, and so I cut the whole, like a moon out of that side, and I have it end here because it's going to immobilize the wrist, but you definitely don't want to restrict that motion. So ending it further up is certainly better than further down. Because I've seen a lot of patients come in and they're having a hard time getting their finger motion back. And that's the thing with some patients, they're just prone to stiffness, and it doesn't take much. Some patients you can put in a cast for like a month and they come out of it and they're like, oh yeah, I'm totally fine. And other people like one day and you're like, oh no, you're never going to move your fingers again. So, you just really kind of want to minimize what you're splinting, but just get to the appropriate joint. And that's what I see is a lot of just finger stiffness, and then pressure padding. We see a lot of splints come out without cast padding underneath them, which I think is dangerous.
So now you should go to the proximal volar crease.
Yeah, if you can, once you put the splint on, if the patient can't make a 90-degree, at least close to a 90-degree angle at the MP joint, then it's probably too far out. Sometimes obviously their motion's limited because they're in pain and stuff, but you want to just make sure that that's not restricted by the cast material. And then, the other thing we see is, I see a lot of splints, like long arm or sugar tongue splints with the patient. You want to try to make sure that if you are coming across the elbow, that you get them at 90 degrees, because that's when they're going to be comfortable in a sling. We see a lot of them, and probably this is because they're on like that, but then the patient starts stretching it out after you walk away. And so they come in with their arm like this, and they're trying to wear a sling, and their arm's sliding out of the sling because it won't stay in. So that's another thing. We do that, and even in the OR, I see that happen sometimes. I'm like, oh, jeez, it's stretched out. So
I like to use a double sugar tongue to really immobilize them well. Do you think that's more than necessary?
you mean like
I do a double sugar tongue from the
like-
crease and then one here to get good, so to make sure they don't move the elbow at all.
Oh, so you're doing like, I got you, like a stir-up thing kind of for the upper extremity. Probably you don't need that. You probably just need the one that comes around. But if you feel like their elbow's going to slide out of the part up here, then doing something to kind of help with that is fine. And that probably, when we used to use plaster, that's what we would do. Like we would never just do a posterior long leg. You would do the gutters along it to kind of help augment it. And I think that probably reinforces it a little bit.
Anything specific about pediatrics you see?
Pediatrics, you know, I mean, they bounce back so quickly. So stiffness with them is a little bit less. They all get better. Is a little bit less of a concern. The only thing I would keep in mind is there are case reports of patients having, you know, this. It's a weird thing, a sepsis phenomenon from splinting. You just need to be aware. When I was a resident, we had one patient who had a splint put on in the ER and came back and was sick, and no one could figure out why. Like there's this closed injury, and no one bothered to look under the splint for like 24 hours. And the patient ended up needing fasciotomies from severe sepsis and probably necrotizing fasciitis that occurred. It was horrible. I think that patient died. But yeah, it was awful. Little kid. Not good. But I mean, for pediatric stuff, I think that the younger the kid, the more you want to put on them to prevent them from doing stuff. So like the young kid we used to put the club splints on to kind of prevent them from getting to their fingers. If you think that they're going to be taking stuff off, you know, casting and then splitting the cast so that it can allow for some swelling sometimes will hold stuff better and be harder for the kid to get off. We always, in the younger kids, aside from like, you know, teenagers who are more responsible, we always would do long arm splints, never short arm for anything, because everything can slide off the limb pretty easily. Even when we cast wrist fractures in the pediatric population, we always put a long arm splint on or a long arm cast because their arms are easy, they can slide out of it. They'll come in with the cast off like, look, came off. Occasionally an adult's arm will be that shape too.
Little ladies.
Yeah, yeah.
And if it's getting wet, they come back to the ER and it's wet, should really replace it again? Or?
And that's the risk with the padding that comes with the cast, is it's like a sponge and it soaks up so much water, which is why sometimes I think it is helpful to take it out of the material as long as the arm is well padded. But otherwise, one trick that, you know, we have the buckets, you dunk it in the bucket and you take it out. Another option is if you're getting too much water on your splint, which is a common problem with those sponge splints, is instead of doing that is holding the splint open at the end so that you're looking at the fiberglass in the middle and then just putting it under a faucet and just letting a little bit of water get into it instead of having it dunked in the bucket, because the first thing it's going to go through is that outer material where it's kind of soaking up all the water. So you'll get less water, but making sure you wring it out as well as you can before you apply it, and taking it and physically like wringing it out to get as much water out is helpful. The more padding you have on the arm, the less likely they are to feel any residual water from it. And especially if you have a wound underneath it, you want to make sure that that doesn't stay moist, because if it gets macerated, it won't heal. And those things take forever to dry once they get soaked. Yeah.
They come back because they have been to the beach.
Oh, right.
And
Then it gets wet.
And they come change it.
Yes. Yeah. That probably should be changed, because if the skin stays macerated underneath, it can become an issue. So even if it, like, let's say Saturday, the kid's been to the ortho clinic or Nemours or whatever, and they had a cast put on, and the cast is wet, you do probably want to take it off and either put them back into a splint or a cast if you feel comfortable. A lot of the stuff that you guys do here, you're doing yourself. Downtown, there's a full-time cast tech, I think, that's doing that downtown, which is nice, especially in the PD population, because that's where they concentrate their efforts. But yeah, you definitely don't want to leave a wet cast on a kid until Monday, for instance. If it's, you know, at night, they can certainly go the next day and get it changed. Probably it's okay for overnight, but longer than that, you don't really want to leave that on. Other questions?
Yes. For all of us, now we got a hand surgeon in the room, we're going to take advantage of it. Hand injuries, when do you want us to call you?
Well, you guys can call me whenever you want.
I know,
I am available all the
Well,
time.
we got the extensor, we've got extensor,
Yeah.
flexor tendons. I mean, what? Because a lot of times we call you, say, just clean it out, put them on
Yeah.
antibiotics, do the skin thing.
What I like to do is if there's a tendon laceration, whether it's extensor or flexor tendon, I usually like to get those fixed quickly. So, you know, a flexor tendon laceration is more urgent than an extensor, and usually it's best fixed within 48 hours. Anything older than 48 hours can lead to tendon muscle shortening, and then it can be difficult to get the ends to meet. So 48 hours for a flexor tendon laceration, especially in zone 2, is probably when the optimum time you want to get it fixed. Doesn't need to be done in the middle of the night, but certainly can wait for follow-up the next day. So just making sure the wound is clean and just putting a couple stitches in the skin is really all you need to do. Urgently, if it's contaminated, then, you know, that's another issue.
Is there anything, you know, we always have our distal tuft fractures, but anything.
Mm-hmm.
We have an open wound. How far up the finger can we
Treat safely?
Yeah.
Fingers are different. I mean, hands are different than feet. Most hands will not get infected if treated properly. So, you know, tetanus vaccination, IV antibiotics, making sure they're on a good broad spectrum oral antibiotic to go home with, washing it out. Pretty much I mean, even into the metacarpals. An open wrist fracture, a radius, an ulna, any carpal injury probably needs to be treated right away. But metacarpal down, you know, probably can be treated within the next 24 hours. We used to have this rule, and it's only recently changed, where open fracture 6 hours. You have 6 hours to fix this. And I think that most of us probably trained under that mentality. But, you know, the orthopedic community is kind of leaning towards, well, you probably have longer to treat these. As long as it's not an open contaminated farm injury, you know, grade 3 tibia fracture, you probably have about 24 hours. So a clean, open hand injury, metacarpal down, can be washed out, loosely approximated, and then sent out for follow-up.
What is your choice of antibiotics, especially now with all the people that are uninsured that can't afford expensive things?
I mean, in a non-penicillin allergic patient, I think Heflex is my preferred medication, which is pretty cheap.
Yeah, that's great.
If a patient has, you know, a MRSA history, then that's probably, you know, a little bit more worrisome, and so you might want to add something for that. Ideally, obviously giving them some Vanco in the ER, but one dose of Vanco is not really going to do much good. But, you know, at least giving them something. Most patients can't get Zyvox without paying out the nose. So,
I'd probably just add Bactrim to the Catholic.
but, yeah, exactly, just
But
something.
I've had some of other people that I've talked to over the phone, and they would like the Levaquin and
Yeah.
things like that. And most of the patients, I work downtown, so
Yeah.
most of the patients aren't going to be able to.
They're not going to be able to. I mean, honestly, I think Heflex is a good drug. It's really going to cover your staph and your strep, and that's a pretty effective thing.
Okay. That's great.
Unless there's some reason to give something else, you know it's already infected with whatever, or they have a recent infection of something else.
So we don't need to call you at 3 in the morning.
No, never call me at 3 in the morning.
And that's really the thing for a Flexor extensive tendon laceration that we cleaned
No.
out and
Yeah.
approximated and
Yeah.
splinted. They could just call you all first thing in the morning, y'all see 'em.
Right, unless it's a dysvascular digit that needs immediate attention, we're not going to come in and do it in the middle of the night. We'll, you know, add it on the next day or at the very least the day after. So again, within 48 hours. But I mean, I see patients, and it's more them, that they go to the ER, they call me, and they're, oh, here's this flexor tendon injury, and then the patient doesn't call for like a week and comes in. So a lot of it, again, goes back to the compliance of the patient. But I mean, we have hand surgeon in the office, what, 3-4 days a week? Well, I'm there 3 days a week. So I mean, I'm in the office on Tuesday, Wednesday, and Friday. So I mean, there's no reason for that patient to not be seen within 24 to 48 hours.
If they're uninsured, do they have to pay y'all before y'all see them?
We usually will.
Copay or something?
We usually, I mean, well, this is more for her. We usually ask them to put some money down before seeing. But if they've been in the Baptist system, and we're on call, then we see them. Somehow we get them in with us. If St. Augustine is on call when the patient comes in, then sometimes we'll encourage them to follow up with them. But, you know, it's kind of what it is. I mean, we know we're responsible for the patients in the emergency room when we're on call, whether we're called or not. Sometimes we bicker amongst ourselves, but that's a whole other realm. But again, if JOI is on call, especially here at Baptist South, because downtown is not an issue, we're on call every day. If we're on call here and the patient doesn't have insurance and has been in the ER for an orthopedic injury, we're still seeing the patients for the most part. If that's not happening, then you need to talk to Heather.
Will you see kids for hand injuries? How
Yeah, I would see a kid of any age. My only problem is that we're limited by the anesthesia department. Anesthesia will not give general anesthesia or anesthetize a patient under the age of 13 here at Baptist South.
Okay.
So anything younger than 13 that requires surgery will need to be done at Wolfson. So that becomes an issue for some of us who don't work down there.
Sure.
But anything 13 and above, I think we're generally not even asking. Below that, sometimes if we review the films or, you know, understand the injury to be something that likely will not require surgery, we will see them. And I've seen patients younger than that who don't look like they need surgery, and then it turns into something more. And sometimes our colleagues at Nemours will help us out in that case. You know, once we realize, oh, geez, this distal radius that looked great now doesn't, we can call them, and they're usually pretty happy to help us out most of the time. Any other questions?